Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight, we're going to be talking about atrial fibrillation and stroke. We see a lot of commercials, a lot of education out to the community about what atrial fibrillation is. There are fancy watches that help us diagnose atrial fibrillation from different companies. So we're becoming more and more aware of this cardiac condition. I have the absolute pleasure of having a friend on the show, Dr. Nidal Isber. He's the head of electrophysiology, and he's a cardiologist at Richmond University Medical Center. And we're going to sort of explain all those terms. Electrophysiology is a lot of syllables. Well, that really talks about the conductions or the rhythm of the heart. So we're going to jump right in. So tell me a little bit about what your training is to become a cardiologist, and then even what your training is to be an electrophysiologist.
First, thank you, Allan, for inviting me. I'll be happy to have this discussion with you about very important subject, which is atrial fibrillation. As electrophysiologist, it's a subspecialty in cardiology that nowadays you have to spend 2 years after completion of cardiac training, after 3 years, to be electrophysiologist. The field has become extremely sophisticated, that become widespread in every hospital in the United States, while a few years ago it used to be only specialized hospital having electrophysiologists. So it's very interesting field and very rewarding result nowadays. It used to be only academic branch of medicine long ago, but now it's interventional electrophysiology that we solve a lot of problems.
Do all cardiologists deal with rhythms of the heart?
Superficially, a lot of cardiologists deal with some arrhythmia, but usually all these cases eventually will be referred to an electrophysiologist to handle it.
So tell us about the heart. What makes, when you have so many models here, we'll look at them in a few moments. Tell us about the intrinsic heart rate. So what is different about the heart than other muscles? And we'll talk a little bit about what atrial fibrillation is, but tell us about the heart itself.
The heart is a very magnificent organ of the body that the Creator has created sinus node, which is the pacemaker of the heart that generate electricity, and that electrical impulse spread all over the heart, giving you a heartbeat. So every heartbeat is started with an electrical impulse that is formed in the sinus node. If I am to show, this is a heart, and this is the upper chamber of the heart. This is the lower chambers of the heart. The pacemaker of the heart start here. It gives the electrical impulse, spread quickly to the atria and to the ventricle, giving you a heartbeat. Atrial fibrillation is abnormal arrhythmia in which the heart become chaotically in the upper chamber, that the rhythm is not organized. It does not activate the upper chamber in a homogeneous fashion. It's just a chaotic rhythm, continuous rhythm, that there is no resting between two beats in the upper chamber, leading to lack of contraction. So the upper chamber, in another word, in AFib does not contract, leading to stasis. That stasis, especially in specific part of the left atrium, we call it left atrial appendage, that is a pouch out of the atrium that make the blood stay static and eventually clot.
Right, so if it's just like a tube of blood when you go to the lab, why does the lab technician always turn it over and do things like that in order to not let it clot?
Right.
So blood will clot if it just sits around for even a short period of time.
Exactly.
And that's the issues that we have with this. Do people know that they have heart arrhythmias? I mean, we talk about, there's always a checklist when you go to the doctor's office. And one of the things they check off is palpitations. But not all palpitations are very serious. Some are just more benign processes. How do you know, and how do you define someone who has a heart arrhythmia?
Arrhythmia can manifest with symptoms. We call it symptomatic. It could be benign, as extra beats coming from the upper chamber, or extra beat coming from the bottom, or it could be more serious, like sustained, like AFib, that predispose for clot. That clot can travel to any part of the body, giving you different manifestation, like stroke if it goes to the brain, give you intestinal necrosis if it goes to the intestine, or to the leg, give you a cold leg. Some arrhythmia might be benign. Most of the arrhythmia coming from the bottom of the heart are not benign, like ventricular tachycardia. That can lead to syncope or sudden cardiac death. Usually, as a physician specialist or as a cardiologist, we will be able to risk stratify these patients according to their structural heart disease, the presence or absence, according to the type of arrhythmia. So every arrhythmia has a different prognostic significance.
And that's why when you go to the heart doctor, you're getting an EKG, and now we call it an ECG.
Yeah, exactly.
Maybe you can tell us what those letters stand for.
Electrocardiogram.
Right.
Yes.
And there's the electrocardiogram. The letters are EKG.
Electrocardiogram.
But that's
yes.
a C. So they changed it
right.
to ECG now.
EKG or ECG,
right.
It's known to be the same term about electrocardiogram, which is the 12-lead EKG.
So is it important for cardiologists or people going to their primary care physician to have an EKG or ECG?
I think every patient who comes to the office should have an EKG because, as you know, even in AFib, there's 25% of people asymptomatic. They don't have any symptoms, or at least when you interrogate the patient, they don't have symptoms. So those people you have to detect. Some people have extra beats, and if it's too frequent and they don't have symptoms, could be a substrate for heart failure. High burden of some arrhythmia that could be asymptomatic could lead to, in the future, after months or years, to heart failure.
So it's very important to get routine EKGs, ECGs on patients. At what age do you usually start?
You know, if you want the truth, it should be started at early age because some people have some congenital heart disease, a primary electrical problem of the heart that you only detected before death. Some people like long QT syndrome or some other problem, young people might have it. So at least one EKG in your life when people are young. No guideline at this point when to start, but in my judgment as electrophysiologist, I want to screen as much as people, at least one EKG once in a while. You can detect hypertrophic cardiomyopathy, that's the most common cause, which is a thickening of the heart muscle that we see once in a while. Some athlete will die suddenly while playing basketball. This thickness, increased thickness of the muscle predisposed for ventricular arrhythmia. You can detect it on EKG in 80%.
I'm sure you're familiar with the realities. They've done a tremendous amount. There was a family member who had a sudden cardiac event, and they are screening high school students now, as part of their foundation, which is really a wonderful thing in order to detect this. Because we do see so many stories of athletes, both college, high school athletes, who have sudden cardiac death and have to, if they're lucky, they're revived because we have all kinds of ways of shocking the heart, and we'll maybe talk about that in a little bit also. But really, it's important for us to screen for that.
Exactly, yeah. I think that's why I said every individual should have an EKG to at least screen for those treatable condition. At least some of them will tell them not to do excessive exercise or athletic to be involved in athlete.
We've had some people talk to us recently about coronary artery disease, stenting, needing to have all kinds of either bypass surgery. And again, we're not going to talk about that specifically tonight. We'll have some other fields of cardiology give us that. Are patients with atrial fibrillation more likely to have coronary artery disease, or is there a relationship?
They coexist. And like AFib and heart failure and coronary artery disease, they have common risk factors. The same risk factor will lead to some of them. For example, heart disease or infarction can lead to atrial fibrillation by infarcting part of the atrium, by loss of blood flow to the part of the atria. Heart failure can expand the atria and predispose for formation of atrial fib condition. So those are risk factors. They coexist with each other, and some might lead to the other. For example, AFib untreated with very high rate, ventricular rate, can lead to heart failure.
So tell us, so let's go even right into this now. So electrically, there's a circuit basically, and it's sort of, to use the term, and I really want our wonderful audience to understand, we used the word pacemaker before. So everybody has an impression of a pacemaker, little mechanical device here. But the heart has its own pacemaker that's not electrical. It's not, we put a wire in rather. So tell us a little bit about pacemaker and the intrinsic rhythm that we have.
Yeah, the heart has separate entities. First, the electrical system, which is me as a specialist only in the electrical system of the heart. Right. The creator has created a small structure like 7 millimeter, which has specific cells that has the ability to generate electricity, and that's what sustain us as alive. That small structure in the heart generate electrical impulse that spread in the heart by a specialized conducting system. We call it specialized conducting system. We call it his Purkinje axis system, which is like a cable. When you want to conduct electricity, you have a cable that conducts electricity. It goes to every room. Every room has a bulb. And that's what happened. The electricity is generated from here, and it is conducted through a specialized conducting system, bifurcate into two, one go to the right, one go to the left, and activate the heart simultaneously and constantly. So sometimes there's some diseases in the electrical system, like when the sinus node or the intrinsic pacemaker of the heart gets some disease, then it becomes slow. So you need a pacemaker to compensate, to accelerate the heart, to make people feel better, to improve quality of life. There could be an AV block, the conduction system. There are some diseases specialized to the conducting system that specifically lead to death of the conducting system, and you need a pacemaker to, otherwise people might have very slow heartbeat. Like we have patients who come to the hospital with 20 heartbeat. So there are several diseases that can result from conduction system.
About how many people in the United States or even per capita have atrial fibrillation?
It's estimated that 1% of the general population have atrial fibrillation. Of course, AFib is an aging disease. It correlates with very nicely with age. Like, let me give you an example. Young people 50 or younger, the prevalence of AFib is 1 per 1,000 people. And that prevalence goes up progressively. In the age of 80 and above, the prevalence is 1 out of 10.
Really? That's a huge amount of people.
Yes, exactly. So 1% is a lot, millions of people with atrial fibrillation in the United States.
So let's assume you get a referral from an internist, from a cardiologist, that we have a patient someone has atrial fibrillation. Is that something that people who are watching us today, and they've heard about atrial fibrillation, should they be petrified of it? Should they be worried? And this whole topic tonight is about preventing stroke. So should they say, I'm going to have a stroke because I have this? Am I going to need to be on blood thinners? Do I need some type of pacemaker or procedure? The word ablation comes in. What does someone do? They went to their doctor today and they were told they had atrial fibrillation. Should they be afraid? Should they be panicked? Or are we different in 2022 than we were years ago?
Yeah. first we have to evaluate how long patient has been in AFib, if we can, from the clinical history, because some people pinpoint to the onset of AFib. Some people don't know, insidiously goes for a while. And only if you interrogate the patient, you will know the onset maybe 2-3 months earlier. He used to be feeling good. So duration of AFib will determine also therapy. The frequency of AFib will determine therapy. But when somebody comes to the office, first we have to look and see how is his heart rate, because the upper chamber is going like 400 beats per minute. The impulse, some of the impulses will make it down to the ventricle, and the vast majority of people will have very high rate in the ventricle. The ventricle will go like 120, 130, 140, some people 150 beats per minute constant. So in order to relieve their symptoms, you have to give them AV nodal blocking drug, a medication to affect conduction to the bottom of the heart. So to make their heart rate from 150 down to maybe 70 or 80
and it
or
makes
90.
it more efficient. It's very inefficient when you're at 150 or 200.
Yeah, exactly.
Right.
It gives you symptoms and congestion and shortness of breath and fatigue. And so you give them medication to control the rate. This is controlling the rate. Second, you have to give them medication to prevent a stroke, to a blood thinner. Nowadays, you give them some oral, the new oral anticoagulant that can work in 2 hours. So put them on that, and then you evaluate them for the conversion. You want to convert them back because AFib is not good. And the more you are in AFib, the more AFib become resistant. There's something we call it AFib begets AFib. So the shorter in AFib, the better for the patient. You don't want to delay them, go home and come in 2 months for follow-up. No, you want to refer them immediately to a cardiologist or electrophysiologist that they will do a shock to the patient. We call it cardioversion, to put them back, to revert them back into normal rhythm. There's two kinds of cardioversion, either electrical cardioversion or chemical cardioversion or pharmacological cardioversion. For the cardioversion, electrical cardioversion, we put 2 pads on the chest, then we press the button of that machine that will deliver low energy shock synchronized with the heart, leading to immediate reversion back into normal sinus rhythm.
I mean, that's a very scary picture. We think about that on television, watching people, and they say clear, and this. But but with this type of situation, it's under a controlled setting with much lower voltage, and patients are given a little bit of sedation so they don't feel it as much.
Exactly.
So it's a much different than when we think about someone
right,
who's
but
not.
it's very safe, very safe. In 25 years, thank God, we never had any problem. We never had any stroke after this because people are prepared by having oral anticoagulation on board. They don't have clot anymore. The second one, we can give pill-in-the-pocket approach, which is a kind of strategy that if somebody has atrial fib every like 3, 4, 5 months and they don't want to be on a stable medication every day to prevent recurrence, then we can give them a medication. It's effective like 80%. After they take a large dose of the anti-arrhythmic medication, they convert in 2 hours or so back to sinus rhythm. They don't have to go to the emergency room. They don't have to have a cardioversion, and they avoid the daily consumption of the medication. So that's pharmacological cardioversion. Both of them are effective, but you have to choose each one what patient is likely to respond to.
So let's talk about our new initiative. So over at Richmond University Medical Center, we have a large stroke unit, a stroke center. And Dr. Isber is a major portion of that, really a tremendous help with this. And as medical director of that, as a neurologist, we basically see a lot of patients who have stroke, and they go into our stroke unit. And what we do at our stroke unit, as you know, and for the public, is we try to figure out what caused the stroke. And if we could figure out what caused the stroke, that gives us a better idea of how we could prevent it happening in the future. So when patients come in, we don't always know what caused the stroke. About 15 or 20% of the time we find a large vessel, one of the arteries from the carotid artery or the big arteries in the brain, are occluded, or they call it a large vessel occlusion. That's where we now have the technology to do something called a thrombectomy to take out the clot. Sometimes we see patients with heart problems. Sometimes we see patients with problems in the aorta. people, younger people with sickle cell disease. There are a lot of things that can cause clotting. But as you taught me, about 20% of patients, 20-25% of patients, we use the term cryptogenic stroke. We don't know what caused it. And that's where you come in. So when I look at a patient and their echocardiogram, which detect the heart is normal, and their carotid arteries are normal, and we see there's a stroke on the CAT scan or MRI, and clinically they've got some deficit, you're the guy we call. And our program that we're really starting up right now is and maybe describe it a little bit to us of what a loop is and how we could follow patients for weeks and months, even longer, to see if what's the yield on it. Why should someone go for this, and how does it make a difference in their life?
Sure. Cryptogenic stroke, as you defined it very well, that is a stroke that whatever we look, we cannot find a cause, like obstruction of the carotid or other entity that you just mentioned. Those people are at risk for recurrence more than actually when you find a cause and you fix it. So that will leave us in a confusion what to do for the patient. Patient is at risk. Should we do something? Should we give them anticoagulant? But it has been shown in cryptogenic stroke, anticoagulant does not work unless you prove there is AFib. Only work in AFib patient that responsible for cryptogenic stroke. Cryptogenic stroke could be a clot coming from the atria, left atrial appendage, that has formed in a patient who has asymptomatic AFib, or AFib that is silent, we call it, silent AFib. So, so those patients, it's estimated that 30%, as you mentioned, of the patient with cryptogenic stroke coming from the heart, 30%. So we have to look to find out. If you do an EKG, you will find AFib in 1% of those patients, so it's not significant. If you do a monitor for 24 hours, you will find maybe 2-3% they have atrial fibrillation. If you do a monitor for 30 days, like this monitor here, we can use for 30 days, we can put it on the chest, we can find maybe 5% of atrial fibrillation. So we need a better detection strategy, and currently we have a loop monitor that can be inserted underneath the skin, which is a device that has a battery sufficient for about 4 to 4.5 years. Wow. Inserted underneath the skin. We make small incision like 1/4 of an inch or less than 1/4 of an inch, and we insert it. That device can communicate with a device that we can provide patient home, and always communicating to transmit to our computer if there's any event of atrial fibrillation. Or patient nowadays, even on an app, can communicate every few minutes, and through an app can transmit to us. Or the patient, if they have any symptoms, they can have this handheld device near the chest, press the button and record anything they feel, and that will be transmitted to us. So this device, it's estimated that in a period of time, the detection will be in atrial fibrillation significant enough, like this diagram. If you don't do the loop, relatively, in comparison, there's like 9 times more detection of atrial fibrillation. And wow. At least 30% of the people in that short period of time study that you will detect by a loop monitor. So what's the significance of detection of AFib? Of course, it has great significance. When somebody has already stroke, they are usually prescribed dual antiplatelet.
Which is like two blood thinners like aspirin.
And clopidogrel, yes, or Plavix. Those are the usual therapy if you don't detect AFib. When you detect AFib, then it becomes crucial to convert patient from therapy, from dual antiplatelet to oral anticoagulant, which Pradaxa or Eliquis or Xarelto or Coumadin. Then what is the significance of this conversion? The recurrence of AFib by this conversion to oral anticoagulant will decrease the recurrence rate by about 60 to 70%.
So it's a huge amount. And we know that stroke is the #1 cause of disability in the world. And patients, it's the 5th largest cause of death in the United States. So we really do have to prevent stroke. So many of our patients, you mentioned Coumadin, are afraid of Coumadin. They've had bad stories, they've had to go getting blood work every week. Where have we come with blood thinners, anticoagulants that are now safer, which has actually now been proven, and effective, and the use of Coumadin is a little bit less, and maybe even, I'll use the term they say on television all the time, valvular versus non-valvular atrial fibrillation. So again, everybody watches TV, so they hear these words. So I just want us to take the nuances of what that means.
Yeah. The new oral anticoagulants are very effective and immediate action. In 2 hours, you'll be anticoagulated, versus Coumadin, you need like few days, maybe up to 3, 4, 5 days to be anticoagulated. The new oral anticoagulant has no interaction with food, like greens. People can eat greens, while Coumadin, you cannot eat a lot of greens because it has vitamin K, and it reverses the effect of Coumadin. The oral anticoagulant don't have interaction with other medication. And you need the blood testing every month or every 2 weeks until you get a therapeutic level. Every patient has different dosing system, because some people might require 1 milligram, some people might require 15 milligram, and that's where the difficulties in Coumadin, and that's why you have to be followed by specialized Coumadin clinic. And
we're much better off.
Sure.
So valvular atrial fibrillations are patients who have abnormal heart valves, like the mitral valve or other valves.
Exactly. It has been shown that valvular AFib would be better with Coumadin, because there are some, the new oral anticoagulant inferior only in that disease. When you have mitral stenosis or mitral regurgitation and you have AFib, so it's better to stick with Coumadin still.
So I'm going to ask you in 30 seconds that we have left. Everybody talks about, you watch television, you learn a lot, but Watchman. So this procedure, I mean, at Rumsey, we have all the procedures, all the things that are available, really as cutting edge as you are. Tell us about the Watchman, and should people think about it?
Yeah, Watchman is a device that can be implanted in the left atrial appendage to close the left atrial appendage, which is a pouch that is the site of in 90% of clot formation that lead to stroke. It's a small device that can be implanted through a catheter inserted in the vein, in the groin. It goes to the heart, and it closes the appendage. And
it works?
It works, yeah, but it has some complication, of course, and we have to be aware of it.
Our half hour is almost over. We only have a couple of seconds left. I want to thank you so much for being here. Really, where we've come, and since my career over the last 25 years, is amazing in cardiology. And really the treatments that you and your team have devised has really been remarkable. I want to say happy holidays to everyone, and thank Dr. Isber for being with us here tonight. And please, everyone, stay healthy.